Hi everyone, I'm Dr. Jonathan Lee, Associate Professor of Medicine at Harvard Medical School and the Director of the Harvard Brigham Virology Specialty Laboratory. I'm joined today by Dr. Lou Teperman, the Vice Chair of Surgery and Director of Solid Organ Transplantation at Northwell Health and Professor of Surgery and Medicine at the Zucker School of Medicine at Hofstra Northwell Health in New York. Welcome, Dr. Teperman. Happy to have you here today.
Jonathan, it is always nice to see you again.
Today we'll be reviewing point-of-care use of anti-SARS-CoV-2 monoclonal antibodies, specifically as pre-exposure prophylaxis. So the first kind of topic of discussion is what considerations should practices need to make for administering IM injections to immunosuppressed patients? I mean, in our clinic, obviously we do tier individuals into clinical risk categories just because we unfortunately just don't have enough of these monoclonal antibodies for everyone. But what about in New York, Lou?
We concur with you. We'd like to have more of this and give it out more. Right now we have more of a site consideration. The patients have to wait for, under the EUA, you're going to observe them for an hour, so they're going to have an IM shot. They had it in their buttock, so they're going to be sitting and waiting, and so it's more of a consideration of where they're going to sit and how they're going to be monitored. But yes, we'd like to give more of this out to the individuals, and we've tiered just like you have because we don't have enough.
So of course, in terms of patient prioritization, the NH Guidelines panel does recommend prioritizing because of the lack of access for a lot of these monoclonal antibodies and the fact that we just don't have enough. And in addition, tixagevimab, selgevimab, the monoclonal antibody combination, for severely immunocompromised over moderately immunocompromised individuals. So, but as you well know, Lou, there's still some reluctance amongst our subset of patients in terms of receiving these monoclonal antibodies, and also some patients where we just have a hard time getting them in to receive these. And I just wanted to kind of hear from you, from your experiences in New York. What do you think have been the barriers to care for monoclonal antibodies?
So we haven't had a significant problem when it was treatment, giving sotrovimab or Regencov before. Now giving prophylaxis, I think specifically for the transplant patients, they're very savvy and they read the literature. They probably read more than you and I do. And they were concerned about cardiac side effects, which I assured them, looking at the data, it wasn't an issue, but I've had a couple of them bring it up. I wonder if you've seen that. Yeah,
that has come up. I will say that the risk of long-term cardiac effects is so much greater with Omicron and COVID-19 infection that to us, I mean, we stress that the benefits we believe really outweigh the risks there. But as you said, there are a number of other structural issues that have limited kind of care for our patients, both for treatment and for prophylaxis, and a lot of that surrounds the fact that many of these treatments and preventative modalities, especially monoclonal antibodies, require it to be given in a healthcare setting with nurses and kind of and places and time where these patients can be monitored after they receive these treatments. And so there's, when it comes to staffing shortages and finding enough rooms to get these patients to receive these treatments, all are barriers to care for sure.
Yeah, it's so interesting you bring up staffing shortages. I mean, we're still down 2,000 plus nurses, very hard to hire them. It's a scarce resource. And we took our auditoriums and made them into vaccination sites. So, the normal standard hospital doesn't exist anymore.
And in addition, of course, there are certain individuals and certain patients who we have a hard time in our practice getting them to access the care that we think that they need. And especially I'm referring to underrepresented, underserved minorities, racial, ethnic minority groups. And I will say that in our healthcare system, we really try to be proactive in terms of seeking out those individuals especially if they're in lower socioeconomic statuses. We know that those individuals just don't get monoclonal antibody treatments as much as those who are in higher socioeconomic status. And so we do kind of target the lower socioeconomic status kind of areas to kind of proactively seek out and educate. And I think that has helped. And Massachusetts also set up infusion and vaccination centers in some of these areas as well, and places where people who are using public transportation can access. And so I'm sure that that's something that you guys have been doing quite a lot of in New York as well. Is that right?
Well, there was a lot of hesitancy, and actually in some healthcare workers. So, we speak about inequities, but, I think it's an educational problem that we didn't speak to letting our staff know why a vaccine is important, why a monoclonal is important. And after you do that, because I think there was reticence into listening to the government and all the controversies, but people are smart, and when you educate them, they're willing to take the vaccine or they're willing to take the monoclonal.
Well, we've come a long way, but there's still a long way to go, right? Well, Lou, it's a pleasure as always.
Great to see you.
So thank you all for joining me today. For more information on anti-SARS-CoV-2 monoclonal antibodies for pre-exposure prophylaxis, please visit the series landing page at exchangecme.com. And for the latest updates on COVID-19, subscribe to Exchange CME's YouTube channel and check back regularly. So thank you, everyone.